Hello and welcome to this presentation on Access COVID-19 Testing and Pandemic Preparedness by Rosanna Hassoun and Madiha Tariq. Our poster provides an overview, and it's very brief. This project is quite difficult to present in a small format, since it entails interviewing, it entails an innovative ethnographic methodology that had to be used during lockdown. There are many, many elements of this project looking into how it was that an Arab American organization was one of the first organizations in the metropolitan area and beyond, in Michigan, to be able to provide testing. And we'll look into that, and we'll look into the elements of preparedness that they developed, so that we can understand and use the Access model in future pandemic preparedness. With Access becoming one of the first agencies in Metro Detroit to provide COVID-19 testing, this presentation explores the components and capabilities of Access as a model for pandemic preparedness. Before I go any further, I'd like to acknowledge that thanks is owed to all the Access frontline COVID-19 personnel for providing the time for the interviews at the same time while they were risking their lives and working very, very long hours on the front lines. And to Access for allowing the research, to Madiha Tariq and Mona Mackey, and to Saginaw Valley State University providing a sabbatical and a faculty unit grant for the completion of this research. Our abstract provides some additional background and overview of this project. So, with Access becoming one of the very first organizations in the metropolitan Detroit area and most of Michigan to be able to provide mobile COVID-19 testing, testing at that time was only allowed for medical personnel and first responders. Therefore, Access, long before they could provide testing for Arab Americans, they were providing testing for other Michiganders, especially those who were medical providers and firemen and police and medical workers. This capability did not spring up magically. The right components, the funding, the partnerships, and the coordination had to come together at the right time. Access was willing to provide testing equity for other communities, regardless of race and ethnicity. And as a medical anthropologist, I know that there is a long history in our area of medical anthropology of studies of outbreak preparedness in many cultures and situations, and we seek lessons for future outbreaks. The Access case provides a model for future outbreaks, and that's why I believe it is important to write about it and to investigate it. And this paper will provide, or this presentation and poster will provide a brief discussion of the scope of medical anthropological studies of outbreak preparedness, just very briefly. We will look at the Access COVID-19 response as compared with other past examples to illuminate the components of effective pandemic preparedness. And Access, because of its historical development, with the creation of the Access Community Health and Research Center, their health personnel, their administrators, their funding beyond grant dependency, and community partners, that includes universities and other medical centers, had the right components at the right time to become some of the first, to provide some of the first testing sites in the region. And the attitude of self-sacrifice and willing to take risks for others also played an important role in Access's testing capacity. The lessons learned from the Access testing experience can aid others in developing the capacity for pandemic and outbreak preparedness. So let me explain why. What we need to do is put this into perspective. So when Governor Whitmer, the governor of Michigan, declared a lockdown due to COVID-19 in March of 2020, the Access Community Health and Research Center jumped into action. And they almost overnight had everything set up. And this was, we don't understand the magnitude of the efforts that had to be made and what had to go into getting these mobile testing sites open. Almost overnight, Ford Motor Company had donated vans, and these were not just empty vans. They were tricked out for medical personnel. They had to have relationships with Wayne State and their medical personnel and their hospital. They had to connect with labs to be able for labs to do the analysis. They had to have the equipment, the swabs and the labels and the test tubes and the intake software and the computers that could handle rain and snow and hot and cold, because they needed them on the front lines. I mean, the enormity of the task begins to hit you when you really understand what's going on behind the lines. But we also have to put this in context of what was happening in the country and in the state of Michigan. The Trump administration had no national plan for how to address a pandemic. They wanted to ignore the whole problem. It would go away. But they left the states on their own to compete for resources like PPE, personal protective equipment, the masks, the gowns, the ventilators for hospitals, all of that. Let's have the states compete with each other, drive the prices up, and that was all they did. Service organizations, hospitals, healthcare providers were left on their own devices to address a pandemic. Not only have we not seen a pandemic of this gravity since perhaps 1918, but we've never seen one where states were left to their own devices. You take care of it. That's what makes it more incredible that Access was one of the few organizations to have the capacity, the resources, the partnerships, and the personnel to be able to do the testing. This is what makes them a model for pandemic preparedness. And we don't just have to do a cursory study of this. We need to delve deep into how this developed over time, that they were able to do this. It wasn't something that they threw together overnight. Yes, many of the pieces came together at the last minute, but Access has developed all of these things over a long period of time. And so this research project used a public health and an anthropological perspective to explore their organizational preparedness and their personnel. Before I go into methodology and results, I'd like to talk a little bit about the literature. And with a poster, there's not much room for literature. So what I've done is choose 3 very representative articles. And I have over almost 100 articles in my database of references, and I am working on a book in this area. So if you need references, I have them. Now these are overview or meta-analysis or review articles. So let's start with Mohandas et al. 2009. Now the literature includes both public health literature as well as medical anthropologists. And this particular article provides an argument for the importance of the roles of models in pandemic preparedness. And so we need a critical analysis of models that work in order to be able to prepare for the next pandemic. That sets the scene for me to say, okay, Access has a model. Let's do an analysis of it and see if it's of value or not. Medical anthropologists have long been engaged in outbreaks. As a matter of fact, anthropologists from the very beginning of the field would go in and study other people in other cultures and have to deal with diseases. So there's a long history of anthropologists being engaged in trying to prevent pandemics, mediations, all sorts of things. So when we look at the literature on outbreak prevention and pandemic preparedness, it's a very, very large field. Innes, McMillan, and Hedges in 2020 tried to do a brief overview of all of that literature, of only just recent outbreaks. And they discussed everything from Zika to Ebola to measles to zoonoses and other illnesses. And so they examined how anthropologists have studied these outbreaks. In addition, they've also looked at vaccine hesitancy across the globe. And while anthropologists have a history of being involved in disease interventions, Paul Farmer, and that name should ring a bell, he's a medical anthropologist as well as a doctor, well known across the world. He proposed a new area of critical research and the use of rapid assessment techniques. And that was in 1996. He's since written quite a bit in this area. But he opens the door for us to use rapid assessment techniques. And during the pandemic, we had to devise some very unusual and more rapid techniques in order to conduct this research. And so there is a literature and a background on that. There's also a literature on doing remote anthropology. So I haven't included that here, but it's there. So this research builds on a background of public health and anthropology literature. In terms of methodology, I had a dilemma. I was locked down in my house. Like so many researchers and medical anthropologists around the world, suddenly you find yourself in your house. And in my case, I had a semester sabbatical, locked in my house. So we had to devise some unique ways of being able to do research. And it's not like anthropologists have never done remote anthropology. There is a literature on this. So this ethnographic study included remote participatory observation. And I have to put the participatory a little bit in parentheses, and I'll explain, as well as interviews of 12 past and present Access employees and administrators. The interviews were okay. They could be Zoom interviews, each one of them at least approximately an hour or more of interaction with each of the persons. Those were transcribed, and I'm using a textual analysis, qualitative analysis software, Atlas TI, to analyze the interviews that were conducted. But as far as doing the participatory observation, I couldn't be there when the lockdown was eased a bit. My own health prevented me from being there. So we devised a way to use our iPhones. And Medea Tariq literally held me in the palm of her hand to view how testing was performed. And this was interactive, so that she could take me and say, here's the role, this person is doing this, we've got this set up, and I could ask questions, and I could ask to see other areas, and to go inside behind the lines. And so it was participatory in that sense, that it was interactive. It certainly was participatory in the sense of a researcher and a community personnel working together. Every time, and other personnel were able to take me into the clinic and show me how the parking lot at the Access Health Clinic, Health and Research Center was set up. So I was able to have those observations, and after every observation, they were not recorded for the safety and the confidentiality of the people being tested, but I did sit and write field notes each time. So I had my field notes, as you would have in a typical ethnographic study. So this research was also predicated on the fact that I had a long-term association with Access and a familiarity with the Access Health and Research Center and previous experience conducting research in the Arab community with Access. I actually have run programs at Access and been employed by Access in the 1990s. So this helped me. The background, I think, would have been difficult to try to do this type of research without having that past experience. So, in one hand, it might bias me to be pro-Access, but on the other hand, it gives me a deeper understanding of the organization itself. So I have to be a bit reflective, self-reflective, when I look at my work. And also, I'd like to note that all the participants allowed me the use of their real names to tell their stories. And so I think that's important. I want to preserve their stories of their experiences on the front line. Because of the scope of this project, all I can do with this presentation is, and certainly the poster, is to provide a flavor of my results. Now, initially I interviewed past and present administrators of Access, Ismail Ahmed, Maha Frej, Hassan Jabr, and Dr. Adnan Hamad, to provide insights into the development of Access that allowed the agency to have the capacity for early COVID-19 testing. And so I also wanted insights into the organizational missions and mission and attitudes that inspired employees to risk their lives and health for others. As I already stated, I do have an insider's view. I was a coordinator of an after-school program for children with learning disabilities at Access. I was involved with their environmental health and environmental justice efforts, and organizing a couple of the Concert of Colors and other things at Access. I've had an insider perspective, but I didn't want that to be the source of this information. I wanted to have the proper information from previous administrators on the development of Access's infrastructure, the capacities, and their mission. Secondly, the pandemic preparedness was discovered from a grounded theoretical examination where the information is revealed from the data collection itself. And I found 6 elements of pandemic preparedness of importance. One was philosophy and mission. The second was financial adaptability and reserves. The old Access that I worked for in the 1990s could not possibly have had the reserves, the financial reserves, to be able to do this. Access now has charitable branches, foundations, and has reserves that enable them to be able to start a new program without writing a grant. Secondly, thirdly, they have an infrastructure. The Access Health and Research Center was built since I first worked with them. So this is a new development. And they also have centers elsewhere, and then they got the mobile capacity on top of that. So that's quite a lot of infrastructure. Fourthly, the personnel, they already had them in place, and they were adaptive, and they believed in trying new things, and they had a willingness to risk their lives. Fifth, they had networks with other organizations and universities. So Access has an amazing network of organizations all across metropolitan Detroit. And these include hospitals and universities that were able to help them get the testing established. And 6, they had a holistic approach to well-being that went beyond testing. So when people needed food, they were able to provide that and so many other services. I think that personally that calling them heroes doesn't do them justice. It doesn't do justice to their efforts of testing when you find out from their own stories about what it was like to test in March in Michigan. We have strange weather. One day it's burning hot and the next day it's snowing. So they had hot and cold conditions. They're climbing up on fire trucks. They're working long hours, and they're even testing during Ramadan. And so when I looked at just the administrators that normally work at the Access Health and Research Center, all of them served on the front lines, even if their job description did not require them to be there. And that's amazing. And I'll talk a little bit about the attitudes of Mona Maki and Medea Tariq, who were willing to work on the front lines. Of course, Medea was organizing, so she had to be there, but Mona did not. Mohammed Khrizet saw that it was his duty. He thought it was his duty to be on the testing line, and he was there. He also explained the difficulties he faced procuring PPE and the testing resources, which is really critical in understanding the kinds of problems that Access faced in trying to set up testing. In these stories of persons working on the front lines, I was struck by all of their willingness to risk their lives and to understand why they were motivated to do this and to help others. But I was very struck by both Mona Mackey and Medea Tariq, and Mona is the director of the Access Health and Research Center. It certainly isn't in her job description to be on the front lines of the testing. She didn't have to be there. She was actually directing traffic and greeting people. Both of them said, and I'm quoting, "I could not ask my staff to do something that I was not willing to do myself." This underscores the attitude of the administrators and of people at Access. This is a picture of Marna Taylor, who works for Access. She's African American. She's a nurse phlebotomist, and she's one of the most important people on the line. And when I interviewed her, she talked to me about how difficult it was to climb the big rigs. And then I realized, oh, these are the fire trucks. We take everything that happens in COVID-19 testing for granted. You just go in, you drive in, or you go inside to a building, you get your nose swabbed, and you disappear and you wait for your results. It's much more complicated than that. When you find out the preparation that has to go in, the PPE and the testing reagents and the nasal swabs and if they're taking blood samples, all sorts of other things. The test tubes have to have labels. Everything has to be prepped and ready before that they can provide testing. There is a way of organizing the line that is critically important. You have to have someone for traffic control. You'll have a mess. There's a greeter. There's someone who takes the intake information and the contact information from a person. That's all that happens before Marna actually does the swab or takes blood samples. And then for probably not so much for the firemen, but for other people in the line, Access tried to provide almost all of its regular services. And people were in need of food. So they provided food. People had questions about children. They had questions about the COVID-19. It spread. And this was in the early days when no one knew very much about it. And so they were providing a full range of services, as much as they could, in the line while people were waiting to get tested. We take all of that for granted. Then there's all of the rituals that had to be performed, of the putting on of the ritual of putting on the PPE, and the rituals of taking off the PPE when you got home, so that your clothes, your PPE is taken off at work usually. Your clothes, people have to remove their clothes, keep away from their family, shower, clean up, and then in order to keep their houses clean and free of COVID, they had developed all of these routines for doing that. Anthropology has long looked at rites of passage. So the testing line is a kind of modern rite of passage. And we have the areas of contamination or pollution on the testing site. It is a site of potential contamination. And then you have the home, which is the area of purity and cleanness that you try to maintain to keep the virus out. There's a great deal of literature on the issues of rituals and the issues of contamination and purity that will come into my study later on as I do more writing. This is a picture of some of the frontline personnel that I interviewed. As you can see, they were out on the front lines before there was actually proper PPE. Fortunately, Mohammed was able to get them gowns and the proper equipment, proper masks, N95 masks very quickly. But that they were willing to do this right, at the beginning of the pandemic is amazing. And I'm so fortunate. I'm proud of them, but I'm also deeply honored to have been able to interview them and to tell their stories. And each one has a story of their experiences on the front line, of describing the work they were doing, the hours that they spent on the front lines, their worries about their families, their rituals for self-protection, all of these things. Each person had a unique story to tell. One of the things that struck me from the interviews that I did with the frontline personnel is that they had, as I said, elderly family members or children. And when I asked them about their major worries, they mostly were not worried about themselves. Their major concerns were worries for their family safety. And I'd like to list the frontline workers: Amani Musaibi, Marna Taylor, Mona Hijazi, Meredith Stay, and Jessica Kowalski. They provided testing and other access resources at the mobile testing sites. And I'm grateful to the information that they provided, and I hope to do justice to their stories. But in the long run, examining the testing site roles, the setup of the sites, the rituals associated with safety that I've alluded to, all provide an insight in a behind-the-scene look at and a provider's perspective of COVID-19. Long after this particular wave of COVID-19 is over, and hopefully eventually the pandemic, insights from this study, I hope, will be able to provide a model for future pandemic preparedness. Here are my references, and I certainly have more references if you need them, if you're interested in these areas. Please contact me at rhassoun@svsu.edu, or also Medea Tariq at Access.